Yes, welcome all to this panel discussion entitled The Scientific and Social and Economic Impact of COVID-19. We are thrilled to have you all here, and we have a magnificent panel of experts that include Dr. Brent Moloughney, who is an Associate Medical Officer of Health at Ottawa Public Health, Dr. Erling, who is an adjunct professor in the Department of Health Sciences here at Carleton University and an expert virologist. We also have Dr. Kim Hellemans, who is the chair of the Department of Neuroscience and a provost teaching fellow, Dr. Tim Pychyl, who is an associate professor in the Department of Psychology, and Dr. Hashmat Khan, who is a professor and chair of the Department of Economics. Before we get started, I do want to point out that if this is a panel discussion, participants can send in their questions through the chat. So please feel free to send in questions. I will try to forward those questions to the panelists as we move along. But we'll get started by, sort of mentioning that we are living in an iconic time. We were celebrating or reminiscing of 9/11 last week and thinking how that particular date was iconic to us. And I do believe that this pandemic this year and this pandemic will be of equal, impact to our lives. And we're only seeing the beginning of the effects of this pandemic. This pandemic is unprecedented, perhaps not because of the number of people it has infected and affected directly, but because of it's unprecedented in terms of the speed of transmission, in terms of the magnitude of the effects economically as well as medically and psychologically. And it's also, is unprecedented in terms of how far and how quick it's affected everybody. The pandemic itself is already killed nearly 1 million people. 20% of those people have died in North America, Canada, United States, Mexico, perhaps even more. It's also taken us by surprise. In many ways, there's no vaccine. There's many vaccines on the go. It has sped up the process to a point where there's a race to develop a vaccine. It is also tested our ability to deal with public health in a way that, again, it's taken us by surprise in how fast it's affected the world. And as such, we're sort of trying to keep up with information in order to develop policies that are effective. The lockdown caused by the pandemic had a massive impact in the world economy, and we're only seeing the beginning of that. And finally, and perhaps a little bit more of the iceberg at the bottom of the sea that we still do not see, it's what will happen psychologically to those people, to everybody in the world, those that are affected, because the pandemic is still not under control. We're still affected. There's a certain amount of fear, underlying fear, that is constant and that is constantly and omnipresent. So we don't know that perhaps a third wave or a fourth wave of this pandemic will be the psychological, the long-term effects that this pandemic will have. So really, we're here to discuss these topics, and we have a wonderful set of panelists. And I'll start by throwing in, sort of the first item of discussion, and perhaps Dr. Moloughney and Dr. Root can first address the next question. And this is, where are we in terms of prevention, treatment, and immunization in this pandemic?
Sure. No, thank you. Thank you for that question, and thank you for the invitation to join you all here today. Maybe I'll do your question in reverse. In terms of, you've touched on immunization, and that we do have this race by multiple research teams around the world, and that's frankly a good idea, because we don't know which one is going to be most successful. As they get into stage 3 trials, and you have the opportunity with bigger patient populations who are being tested where you can pick up rare issues, or subpopulations where the vaccine may not work as well, those sorts of things. I think, realistically, obviously we want the vaccine yesterday, but realistically, for this to go through stage 3 and to be cautious about this, I mean, we're doing this faster than the other vaccine, and so we have to make sure that we pick the best vaccine that has the best profile in terms of safety and effectiveness. We're then faced with, how do you immunize everybody in the world, in a way? And, I think back to the last time I was in Ottawa, when I was a resident training as a specialist in public health, and that was during meningococcal outbreak. And we immunized basically all of the school children of Ottawa for meningococcal disease at that time. This is the early 1990s, to place it. And it took us, a while to be able to do that group of people. And that's, of course, only a segment of the overall population that we need to test. So there'll be some needing to prioritize who gets immunized, because not all the vaccine doses will be available at once, and we'll have to be able to put it out in a way that is feasible in terms of some of the mass immunization campaigns where we had hundreds of people in a gym all crowded together to get a needle. We're not going to be able to do that, right? Because people are going to be susceptible. So we're going to have to think those things through, but it'll take a while. I would think a period of many months to immunize everyone once a vaccine's available. Treatment, unfortunately there's no cure for this. There's little gradual improvements, things that came out in the last few weeks saying, for people with severe disease, the use of steroids helps, presumably with the anti-inflammatory process. So that's slow progress. So the best thing we can be doing right now is preventing. And we know what works. I mean, compared to where we were in March, we have a lot more confidence in knowing, if people keep their distance from each other, if people wear a mask, if people don't go out if they're sick, those sorts of things are effective. The challenge, and I'll be interested to hear, other people in the panelists, is as a community to be able to sustain that week after week, month after month, because we're already seeing a bit of fatigue, I think, coming through the summer. And as we continue to open up, that balance of being able to keep those controls in place while we're increasing our number of potential contacts. And so I'll stop there.
So I have a question, and this is a question from the audience, and perhaps Erling can address this question as well. There's a question, and the question reads: why is it necessary to pick the best vaccine? Why not a good enough vaccine? Or, I mean, Russia has a vaccine out that they say is almost there. So why not just pick good enough?
Thanks, Alfie. This is Erling Rudd. It's fascinating question. The Russian vaccine, by the way, called Sputnik 5, which for someone born in 1957, when the first Sputnik went up, is highly relevant to my background. But the issue you have in vaccine development is that to get a vaccine out in the timeframes we're talking about, we're having to push the envelope as it is. It usually takes up 10 to 15 years to get a vaccine through the development pipeline, through all the clinical trials, approvals, and then scale up. What we're doing here is actually reducing it down to maybe 2 years, which is amazing, to be honest with you. We didn't even know the sequence of this virus in January. And in September, we have, 33 different vaccines in clinical trials right now, of which 6 are in phase 3 clinical trials. So I would say we have lots of candidates. The first candidates likely aren't going to be the best. If you take a look at what was put in initially, the very first ones were RNA-based vaccines, very new technology. You should get a very quick response because you can produce a messenger RNA, which is the approach used here. and inject it into people, which they did very, very rapidly. The old traditional approaches is to take the virus and actually inactivate it. So the first vaccines would have been inactivated vaccines. The Chinese put a couple of those in there in phase 3 clinical trials as well. Then you have different approaches. You can take the sequence of the, this spike on the outside of the virus, what they call, coronavirus. It's called corona because it's called, a crown. The crown is the spike protein. So different groups have either taken the sequence for the spike protein or expressed the protein itself, and they're injecting it with a variety of different approaches, some to induce better immune responses. And that brings up the big question: what is the best immune response for protection here? We still don't know. We know what's probably bad. We know an inflammatory immune response is likely not going to be very good in prognosis. If you're going to induce an inflammatory response after contact with the virus, you're probably putting the individual into risk. So different adjuvants are trying to avoid those immune responses. Those would be the next phase of vaccines that are coming through right now. So yeah, okay, the first ones are not going to be the best. That's what's in clinical trials. Likely some of those will come out, but we're going to have follow-up vaccines that will be better and better and induce better responses, probably better protection. You don't want to have a vaccine that's maybe only 20% effective. You're really trying to get something that's in the 80% effectiveness range. And that's really what we're targeting here. But you don't want to pre-expose people to, to bad prognosis if they actually do come in contact with the virus. That's it.
So in the meantime, and that's really, it's interesting because then we're really facing with having to wait for it, right? So one, and again, this is a question from the audience. It's an interesting question because, again, people are trying to sort of determine, well, am I sick? Am I not? Is this COVID? Is this not? Yes, the easiest way is to get tested. But again, the testing capabilities are still a little, people go on and wait 3 to 4 hours and sometimes they won't do it, right? So I have a question from the audience saying, how reliable is body temperature for saying that one has or has not been infected? These are common questions that people have. Do I, if I have a fever, does that mean I have COVID? Or, probably not, but I'll let the experts, perhaps Brent, answer that question.
Yeah, no, it's a tough, stealthy virus that sort of, as you started off saying, it spreads fairly easily, but because people can have quite mild symptoms, it flies under the radar often, particularly in sort of vulnerable settings where it's spread before you necessarily know it has. While we do recommend screening with temperatures in various higher risk settings, it's not by any means a perfect item to test, because people can have a runny nose, they can have a sore throat, they can have a headache, they can just be feeling unwell, and those are just as important. So when we started off, we said fever and cough. Those don't always occur. They don't always occur at the very beginning. So we're at the point now where it's a fairly long list of symptoms that sound an awful lot like the common cold or flu-like illness that we have to take seriously. And we, at this point, need to test those individuals to make sure that they don't have COVID.
So
could I add one thing, Alfie, in regards to how good the tests are? If we look at any of the tests out there, including serological based tests or the RNA tests that are being done, or the viral RNA tests, it all comes down to how sensitive is that test and how specific is the test. And you'll hear of a lot of different rapid tests and tests that are similar to a pregnancy test that sound great, and individuals should be able to get rapid responses. However, if the sensitivity is not good enough and the specificity is not good enough, and we're talking 99% or above, then you give people a false sense of security because the potential positive predictive value and negative predictive values are not what they should be. And this is particularly important when you have a low incident population. That is, not that many people in the population are actually infected. So the under 10%, for example, levels. Then those sensitivity and specificities of the tests become extremely important.
So I mean that, and again, moving the conversation, right? Since we don't have immunization, there is that looming, I guess, fear or creeping fear that there's going to be a second wave. And given I mean, the impact of the first wave, right? What are your feelings? And this is a question that I really would like Hashmat to address, because I mean, the impact on the economy was massive all throughout the world, right? Governments have done a huge amount of work trying to deal with that impact. In some cases, as one of the questions that just came in, like our neighbors down south have actually sort of opened up their economy in a way that some would consider irresponsible. So what is your feeling, and should we be concerned economically about a second wave?
Yeah, thanks first of all for having me on this panel. It's really a pleasure to be here and to listen to other panelists. Regarding the issue of sort of the impact on economy, that's fundamental. So it's kind of it's a health crisis that we're dealing with, and which is also an economic crisis. So this is exactly where a lot of recent research is trying to kind of come up with new insights and answers, and more sort of quantitative answers about how best to reopen the economy. So epidemiological models say that, because we don't have a vaccine, the first early phase of the pandemic was a lockdown. So we lock down the economy, slow down the contagion. But now the issue is what impact does it have on the economy? Of course, it's a very drastic recession that many countries have entered into. And how do we reopen the economy? This is exactly where the research is focusing on, coming up with answers to reopening plans. What is the sort of the least costly way for the economy to reopen? If we just reopen the economy, I mean, we have the fatality rate. If just take, say, 1% of the population, 1% of Canadians would die. So that's a huge, horrible outcome that's on the cards, right? So how do we reopen the economy, which sort of looks at the cost, the least costly way of reopening the economy? And this is where I think very granular research that is happening, looking at sectors, looking at sort of the age profile of the population, et cetera, is coming in really handy. And this is ongoing work, so this is ever since the pandemic, declaration of pandemic in March, there has been an enormous work in terms of just kind of producing new research on this topic that has come through. And we're learning a lot of new aspects of how to reopen this economy. So I think that conversation needs to really come through. The lockdown is a blunt tool, and it's well recognized. The economic costs associated with the lockdown are just enormous.
So it seems to me like there is a balance that needs to happen between the economics and the health aspects. And I guess that we're seeing that one of the things that we're witnessing right now is that particular fine balance that needs to be attained. I mean, one of the biggest conversation topics in the past couple of weeks, and raised up by one of the members of the audience just now, is children going back to school, right? And there's that inherent sort of fear of sending them back to school, where they may be exposed, where they may expose their teachers, or they may get infected and bring the virus and expose their family, right? But on the other hand, if the children are not in school, then the economy suffers, right? And I know that, and then those are the sort of economic aspects, and then you also have the psychological aspects that perhaps Tim and Kim can, Dr. Pychyl and Dr. Hellemans can sort of tell us a little bit about, right? Which is, what can be what is the impact of having the kids at home, not socializing, not having the normal sort of, or what we consider the normal interactions with peers their own age and so on. So maybe we can have a bit on this conversation. And Dr. Hellemans, would you want to start us off with some of that?
Sure. And again, I'd like to also thank the organizers for including me on this panel. And I apologize if, how is my sound? Is it okay? Because I was meant to be at work today because there's better bandwidth at Carleton, but my daughter woke up with a scratchy throat. So here I am, the living, breathing impact of this system. Had to keep both my kids home. We just found out that the line at the CHIO assessment at Brewer is 5 hours. So we ex-nayed that. Neither my husband nor I have 5 hours to donate in any given day. And my husband just took her to Heron, but the garage door just opened, so I don't think they lasted very long there. So I'm here as a scientist and as a mom to tell you, like, from the mom perspective, this has been really, really challenging. My kids started 2 weeks ago. They're in the French Catholic system, so we're a couple weeks ahead of the OCDSB. And so I can see firsthand how this has had an impact on my kids. They're very happy. They're happy at school. They are overjoyed to be with their friends, to be in a routine, to have that structure again. And I'd love to hear Tim's comments more on that from a developmental perspective. From a scientist, what I look at is, in fact, the mental health piece. So I specifically look at how the COVID pandemic has impacted mental health among our student population. So myself and Alfie is one of my collaborators, and I have other collaborators at Carleton and at the Royal Ottawa Hospital. What we're looking at is looking at this vulnerable population. Our students are, we would already consider them a vulnerable group in that undergraduate students are more likely than the general population, or students aged, people are student aged, are more likely than the general population to have to experience depression, anxiety, or another mental health disorder. And what we're doing is, with COVID, or what we're doing, but what COVID is doing is imposing yet another stressor, right, on this population of students, and it's another burden to them. And so we, I'm not the only one that said this, is that with the COVID pandemic, what we're going to see is another wave of this pandemic, which is going to be a pandemic of mental health. So it's not just the students. I think every population is experiencing the strains and stressors very uniquely. So my population, the working parents versus my parents' age, that generation, they're very shut away from their friends because they are more likely to have underlying health conditions. They're an at-risk population. They're more shuttered at home. And then again, you're looking at the children. So the whole spectrum of developmental ages are experiencing the stresses and strains of this pandemic very uniquely. So I'm happy to take any questions that relate to the kind of work that I do, but I'll turn it over to Tim to hear his comments on this as well.
Well, thank you, Kim, and thanks to the organizers for inviting me as well. I've been thinking about this panel for weeks because the invitation went out quite a while ago, listening to the media, because every time you turn on a radio, you hear about the psychological effects. This is a living experiment. Brent began, or actually ended, his comments by saying, if people do this, if people do that, like if we stay 6 feet apart, if we wear masks, and it really comes down to a great deal of understanding human psychology. In fact, on the Current on Friday, Matt Galloway was interviewing Patty Haidu, and she said, my biggest concern is Canadian well-being, their mental well-being. And because she said, it's unusual to stay apart. It's exhausting to stay apart. And so for all of us, we're feeling this. We are in this natural experiment. But you asked particularly about returning to school. Well, like Dr. Hellemans, like Kim, I'm a parent and a scientist, psychological scientist, yet at the same time, I'm in that vulnerable population, Kim. I'm a dinosaur dad. I'll be 65 next month, and I've got a 12-year-old and a 15-year-old. And to see my girl go off to school, I feel like, wow, there's a vector coming into my house. What's going to happen to me next? So we're living with these things. And Alfie, you used the word fear. I mean, we can't have this conversation without using the words fear and anxiety. There's tons of it, whether it be the comments that Dr. Khan was making about the economy and people without jobs, or just fear of our well-being and our health. Now, with kids in particular, you know, going back to school, it's so much depends on so many factors. And that's why this living experiment is so interesting to psychologists. You know, for someone who's in their teens, they just have to be with others right now. And yet at the other extreme, I remember sharing some of these thoughts early with my colleagues. One of my colleagues said, you know, I was playing with my son. He's 4 years old. He lives in Centertown. They were out on the street, and a person came walking down the street, and his son shouted, "Human," and ran back to him in terror. And he said it would have been hilarious if it wasn't so sad. So is it having effects on our children? Yeah, all sorts of different kinds of effects, whether it be because of isolation and not being with our peers, or learning different things about being with others that estranges us from others. But we are social beings, and social isolation is inherently harmful to us in so many different ways. So, going back to school, I agree with so many, not just the economics of going back to school, but our children need to go back to school in so many ways. But I have to tell you, only my daughter went. My son, who's in grade 8, I kept him back because the elementary schools didn't downsize. And I just don't feel he can physically distance. So, you know, we're all as parents making these very difficult decisions too about evaluating risk. And as I'm sure Dr. Khan can tell us better in terms of behavioral economics, we're not really good at estimating risk, right? We're very risk averse. But some opening comments, at least, about the fact that, yeah, I think that part of this whole thing is to understand the long-term effects psychologically, because I was listening to one other psychiatrist talk about this, and he said, you know, one of the things we're not putting on the table is that once you've had a mental health crisis, it's easier to have one later on. So there's a whole potential for an echo pandemic here.
So it's really, really interesting because in this conversation, we've identified perhaps people over 50 or 60, I included. We've sort of talked about university students as vulnerable. But really, I mean, in general, there seems to be, in terms of the health, health status and so on, the rate of infection mortality, there seems to be, sort of an economic vulnerability as well, right? And perhaps we can comment onto that, because it seems that the virus, at least in Canada and the US, is affecting those that have, that are sort of, making an income that is less than the average. So perhaps we can comment on this.
One thing that I'd like to say on this is that, what we've seen here is in the labor market, the ability for individuals to work from home, for example, so remote work option. That's it is a significant part of the economy that is able to work at home, but there is another part of the economy that is essential services, so that they are not able to. They have to. They can't work from home, basically. So you have, just take, for example, garbage collection. So you have to kind of work, someone who's working in that industry has to be outside. But even if you consider that particular example, you can have the person who's driving the truck, their exposure is different. The person who gets off and interacts with other people on the streets, that risk is different. Someone who's sitting in the office remotely in that sector, so all this granularity, this heterogeneity in how the contagion is spreading is very important in trying to really understand how to kind of reopen the economy. And we talked about fear. So some of the research that I'm doing with my co-authors, we're trying to kind of get a sense of this, how to model this fear. So we have the pandemic is influencing the economy and behavior, but how does behavior itself interact with the pandemic? So here the idea is that, as mentioned just now, that we're all the time making these decisions, whether to send our child to school or not. A new vector would be created if one other person goes out of the house. So what we're trying to do, at least in my research, just try to kind of model this aspect of how that affects the interpersonal contacts and influences of this choice. I'm going to balance my fear of getting infected with my desire to, like exactly that was said, a human. So my desire to be outside, see, interact. So we're trying to kind of balance this and trying to see how this interacts with the contagion. And again, this is putting in a model that can then help us give some insights into different scenarios, different reopening scenarios of the economy. So that's sort of the focus of my work, but it sort of captures some of these things that have that are central to the discussion that we're having, sort of fear versus a desire to be more socially active and meet other people versus the risk of contracting the virus.
So there's this is an interesting question from the audience. The question goes, running parallel to this inevitable scenario the world finds itself in is the decades of long implementation of immune suppression, modulation, and misdirection, anti-metabolites, antibiotics. So the question is, how do we talk about the current situation and not talk about it being obvious result of what we have been doing? So I guess the question refers to, are we immunocompromised because we have been exposed to antibiotics for the past 100 years? Or could this be a reason? And perhaps Dr. Root or Dr. Moloughney can comment on this.
I'll start. So, I mean, I think the most relevant piece here is that this is a novel virus that humans haven't seen before, and so none of us are immune. We have, it's a virus we haven't seen, and that's the challenge. So we have widespread susceptibility to a virus that spreads easily and spreads in a stealthy fashion that we don't have a vaccine for, and we don't yet have effective curative treatments. So you put those things together, you're going to have rapid potential for spread, which is what we saw in wave one, and the need to take dramatic action to stop it. Before I just turn over, there's just one other thing I just want to touch on Dr. Khan's comments in that there's risks for being exposed. Some of us can avoid a number of situations because we can work from home, but others don't have that choice, so they have increased risk of exposure. But then on the flip side, then there's also an increased risk of being exposed at home, because not everyone has the opportunity to spread out and isolate. If you're living in crowded circumstances, and we've seen that one end of the spectrum, family shelters where a whole family is in a room together, in that kind of environment where they're sharing a kitchen and a bathroom, this kind of virus will take advantage of those social conditions to spread. But even if you have an apartment, but there may not be a separate bathroom or a separate space for you to be able to isolate. So you have these twin sides, and there's certain members of the population who experience both. And therefore at increased risk of disease. And certainly when we've done our survey work, those individuals who are low income and racialized are at increased risk and increased mental health challenges as well as financial insecurity. So there's a lot of social determinants of health at play here that's being exposed by this virus.
Yeah, and if I could just add, we're seeing research now from personality psychologists. For example, there's a paper just recently published out of Italy that shows people that have high emotional stability, more of a sense of self-control, better coping mechanisms under stress, they're doing better overall. But that's neglecting so many of the variables that Brent just mentioned, which are huge, these contextual values. We have to be very careful. You used the term earlier, Alfie, about resilience, that we don't think about it as an individual attribute because it's misplaced then. We have to make sure that we're dealing with this as a community because if we don't, there are a lot of people that are inherently at risk because of situational factors. And so I want to make sure that we always separate person by situation and put a lot of emphasis on situation.
And that brings up an interesting sort of topic as well, which is being put under these situations and whatever the personal situation is, I mean, overall, people have been sort of tracking how people are responding to the virus, right? And perhaps Dr. Hellemans can comment on this as well. But, how are people coping in general? How, are people coping in a way that is adaptive, as you suggest, Tim, that some people do, or this variability? But in general, are we seeing some trends in terms of their coping styles, coping mechanisms to deal with the stressors of this pandemic?
Yeah, sure. And so we do have some data that we collected this summer asking students explicitly, how are they coping? And bear in mind that when this data was taken from students who are currently registered in courses at Carleton. So already students that have the mental capacity, the physical capacity, and the economic capacity to take a course is a very different population than students who may not be able to do that. But what we were seeing was some interesting gender differences. So overall, we saw first that females tended to cope worse off than males in terms of the pivot to online learning. This was very clear when we asked students how they felt when the COVID pandemic had impacted their ability to learn, how it had impacted their ability to focus. Females said it impacted them to an extreme or great amount compared to males. More females said that compared to males. So we saw some gender differences there. And we also see some gender differences in the method of coping. And specifically, what we're seeing is trends with increased problematic social media use. So I want to make it clear that, first of all, everybody's more on social media. That's what we're seeing, is the quantity and the amount of time that they're on social media. Most of our students are saying, yes, they're going on social media more. But we actually have scales that measure problematic social media use. And you might wonder, what does that mean? Well, I've been an addiction scientist for 15, 20 years now, and we're starting to recognize that people can engage with social media. They can engage in eating, they can engage in sexual behavior in increasingly problematic ways that look like what we see with alcohol use disorder or in a cannabis use disorder. So we can take the scales that measure problematic cannabis use or alcohol use, and we can kind of swap out the words a little bit. And what we have is a scale that says, hey, when you're not on social media, are you feeling preoccupied with it? Are you feeling more anxious or depressed? Do you find that when you're going on social media, you're spending a lot more time than you had originally intended, and so on and so forth? And we are seeing increases in the scores in these problematic social media scales with our students, and again, trending towards more females. So what we did see originally was kind of an uptick or higher levels of alcohol and cannabis use in our student populations. And this was early in the pandemic. In the summer, we didn't really see this as much, but again, we interpret this to mean that students are probably, they're doing better off in the summer for a variety of reasons. We are continuing our study well into the fall. And it's our prediction that we're going to see, again, probably some increases in maladaptive coping with alcohol and cannabis and other substances, because students are back to quote unquote normal, right? They're back to their normal fall semester, but we're still in a global pandemic. And so they're still going to be having now these more socially isolated. They have lost their supports on campus, their peer supports, their professor supports, their face-to-face supports. So we're really just keeping an eye on that, because we think that that's something that we might see.
Kim, there's a question from Claudia Butera to you, which is asking if you are surveying also faculty and staff to see how they are coping.
Sorry, I missed that first part. So are we asking faculty?
Whether faculty and staff are responding the same way, whether you're surveying that or not.
No, we don't currently, we don't have the ethics to look at faculty and staff. We're only looking at students, because that's how we get the data when they're registered in a course. But that is a good question. I'm not sure if there's other folks on campus that might be looking at that, but I know there's lots of other surveys that is through the Canadian government looking at coping, as well as CCSA, the Canadian Centre on Substance Use and Addiction, are also do a lot of surveys looking at these kinds of questions, but I don't personally.
So if I could just jump in there. Sorry.
Yeah. Go ahead.
Particularly for listeners, if you go to depressed.ca, depressed without that second E, so the word depressed and then a D at the end, that comes out of McGill, but it's a living systematic review. And there's interesting information there about changes in depression and anxiety related to the pandemic. And so you're going to get an insight into other than student populations in that sample as well. So depressed.ca.
And on the same topic, but perhaps at a more general level, I mean, the pandemic has emerged on the backdrop of a very intense political, national and international political mess, right? There's there's all of these international events. We are hooked to Fox News and CNN down south to see what's been a very incredibly stressful push and shove, social unrest. We are seeing as well, a number of events related to the environment and the decimation of our environment and the side effects that are springing up out west, that sprung up in Australia earlier in the year and then are now out west. All these hurricanes, tornadoes that are, of a magnitude that are, so we are seeing all of these different stressors. How do you all, and I'll put this question to whoever wants to answer. I don't want to point out a particular speaker because these have economic, medical as well as psychological effects. So perhaps we can comment on this. Hashmat.
Well, I'm happy to jump in. Just with
in.
one word, and that's boundaries. Whether it be working from home and having to create a boundary between your professional life and your family, or using social media and consuming the news, whereas children might be using social media more, we're getting a lot of adults preoccupying themselves with news feeds, and it's destructive. And so that word boundary is really important. Again, probably going back to the word you used earlier, which is resilience. If you can set some rules for yourself, you're going to step in the right direction to not overconsume that, because there's so many things out of our control. And if that's what's feeding you before you go to bed at night, you're going to be on a downward spiral for sure.
So there's a question from the audience. Go ahead.
I just wanted to add to this sort of a broader perspective that you have that you brought up. On the economic side, what the data is beginning to show is disproportionate effects on certain groups, low-income groups, and sort of all kinds of different sectors. Within each sector, if you look at sort of the different income groups, minorities, immigrants versus non-immigrants. So all these different categories, economic categories, the effect of pandemic is getting amplified. And even before the pandemic, in the pre-pandemic time, we had been seeing this growing trend of increased inequality, both sort of the wealth inequality, income inequality. And so one of the concerns is that this pandemic is going to really amplify these underlying trends that have been discussed for the last, that have been observed over the last 20, 25, 30 years. So that's a big concern. And this is not just about industrialized countries, this is across the globe. So that's just want to kind of add that it is from a bigger perspective or sort of a broader perspective, this is a very big concern.
Dr. Rood, there's a question from the audience that says that asks whether this pandemic has eroded the trust in science. What are your thoughts on that?
I guess it depends on who you're just addressing it to. I think if we look south of the border, yes, there is a definite mistrust in science in certain sectors of the population, maybe even including the president. But in general, I'd say in Canada, there's a fairly strong trust. But I think what we're starting to see is this sort of disconnect a little bit between science and health and policy development. And especially right now when we're deciding, okay, we have to open up the economy, we have to do this. So there is this sort of pull and push aspect of how do we deal with the data coming in, the advice coming in from science, health, and economics, and how are we going forward? And that would include how do we open schools? So I can imagine that the population in general is looking at it going, oh, wait a second, the scientists were telling us this back in June, and now they're telling us almost the opposite. And I think we have to worry about the messaging we're giving to make sure that we're consistent in that messaging in regards to how to prevent infections and the fact that, yes, we're opening up schools. However, we're putting in place processes that should try to minimize infections. But I've seen it in multiple areas. I was just actually at my daughter's wedding in Nova Scotia, a wedding of 6 people versus 600. And yes, looking around the community, there was this sort of fatigue in regards to the message coming out from science, and people starting to go back to their old approaches to social networking, which is a bit of a concern. So I'm a little worried about the sort of the fatigue from the message.
And I guess this is perhaps again a question for Dr. Moloughney as well. From the audience, and they're asking. The question is, can the panel comment on aerosol transmission of the coronavirus and whether there is acceptance of this? And I'll let you comment on this, but I believe that there is.
Yeah. So the aerosol transmission and airborne transmission, they sometimes are used a bit interchangeably. I mean, this is a respiratory virus. We know it spreads primarily by droplets. And so we consider, for example, a high risk exposure is, you say we're speaking with someone with, less than 2 meters away for 15 minutes. So you meet those criteria and we're going to consider you a high risk contact. Certainly, there's been a number of studies saying, well, no, they're even finer particles which can stay suspended. The thing about droplets is that they fall. That's why there's a 2 meter. They don't travel usually much farther than that because they have some weight to them and they fall to the ground. Finer particles, so-called aerosols, have the ability to stay suspended, to drift on currents, and there have been some areas, particularly in a confined space, particularly if there's something that's also moving the current. So say you're right downstream from a fan or an air conditioner that's moving that in a small restaurant, that kind of thing, where you can have transmission. But those seem to be more exceptional than typical. The sorts of transmission that we're seeing is really around droplet spread. But it occurs very, very easily in confined indoor spaces.
Yeah, I'm going to add to this a little bit. This is Erling. Having worked in high containment labs for years, one of the things we do is increase the rate of flow through that room. So the number of air exchanges per hour increases to try to minimize that aerosol transmission potential. And I think, some of the schools have, decided we're going to keep the windows open to keep that airflow going. There's discussion of increasing the type of filtering systems that are being put into buildings to minimize that sort of aerosol type transmission. But I think, as Brent stated, droplets are still, risk-wise, they're the higher risk versus an aerosol. But, as a virologist, aerosols can still contain virus. So yes, the dose is lower, but it's not zero.
So as a question for Dr. Hellemans or Dr. Pychyl, there's from the audience, they're asking whether, given the fact that when a mother delivers a baby, and they have to remain isolated from everybody else. So it's just the mother and the baby. Do you feel would be an impact or a long-term impact on the baby itself from this sort of, I guess, bubble, this very, yeah. this bubble between mother and infant?
Yeah, so what I would feel is that initially when a baby is first born, and I can tell you again, my daughter delivered a baby in January, so she's now 8 months old. She's lived most of her life in very much a bubble. Early on, that bonding between the child and the primary caregiver, often the mother, but not always, is what is crucial for brain development, right? It is that, science is very clear on this, that if that caregiver interaction is disruptive in any way, that does have drastic impact on brain and therefore psychological development. I think what you're asking more is social interaction, right? Because if a baby is within the bubble with the parents, it should be fine. But certainly when babies start to become more, they start to engage with the social world, they start to, really look around and start looking at other faces and imprinting onto other family members. And then I would say probably around 18 months is when babies really start to become engaging and interacting very readily with others. I think that's more what we need to be looking at is the long-term impacts of babies, or toddlers and young infants, not having those regular social interactions. And my whole research area is on social isolation, so I can say what we do have is data that shows like the really, really bad stuff with this is more related to things like with the Romanian orphans that were kind of put in these horrible, neglectful living circumstances. And that's really not what we're seeing here. It's almost like we haven't really seen it. Even when you look to Dawn of Humanity, where, our conspecifics lived in small social groups, they were still living in small social groups. They weren't like individual families. So I say it's really hard to know. I would, part of me says like, if this is prolonged, if they're not engaging with their playmates or their peers regularly, this may well have an impact. But then I ask the question, well, what about virtual exchanges? If they're, on toddler time with somebody that's leading something on a Zoom call like this, will it have a similar impact? I don't know, right? Like Dr. Abizaid said, we're all living in this kind of great sociological experiment, and we have some hints as to what this may happen, but who's to say? So Dr. Pychyl, I would love to hear what you have to say as well.
Oh, you're muted. Yeah.
It's shouted at me, you're muted. I'd only add that we have the possibility to form these bubbles, right? We're being told what size those should be. So I would certainly encourage anyone who's in those situations to try to find those trusted others and create that bubble, because you do want as much social interaction as you can, but you're trading off, go back to that trade-off, safety and interaction. But we don't have to be completely isolated. We can bring people into our bubbles, and that's another social negotiation. And that becomes another crazy issue of trust. Do I know you're doing what I'm doing? But I would really encourage anyone that's concerned about those issues is to find others so that they can continue as normal social interactions as possible.
Just like we talked about, the fine balance between going back to school and being safe, because it's interesting. I guess one of the questions, for example, that my wife was having when I was telling her about this sort of meeting was because it all seems to be we're all in this for the long run. This is going to be not a quick race, but a marathon, right? So how do we increase that resilience that we need? I think this is a question that everybody wants to find out, and I really perhaps as a final comment from the members of the panel is, what can you tell us? How can we improve that resilience? How can we, be ready for the long run?
Oh, maybe I'll start. I think, what was previously said about the importance of socialization, we're social beings, is to find and negotiate a way to do that while still reducing the risk of transmission. Like, it's that balancing act. And so when we were starting to see new cases in the midsummer, and a lot of it was large get-togethers in younger adults, but not just younger adults. And so we tried with our messaging, and I'm sure others will give us feedback in terms of, how we might have done it better, was to say, we're not telling you not to socialize. It's a really important part of all of our lives, but certainly really important developmentally for many in certain decades, and it's to do it wisely. So you have to think ahead, though, in terms of how many people can I have in my backyard, or if as we get into winter, in my home, which will be even fewer, where we maintain our distancing, where we make sure if people are not feeling well that they don't come or don't host the party, even that, even though the province says we can have 50 people indoors, that's really not a good idea in our homes. Like that's for businesses, right? I mean, most of our homes, maybe it's 2 or 5 people max. If smaller living conditions, probably less than that, where we can still be social, but have some boundaries or some rules in terms of doing it in a way that allows us to interact, but really doesn't give the virus a chance to transmit. So that's around distancing and masking and not doing stuff if we're sick. So it's finding a way to try and navigate ourselves through this living with COVID experience, which will go on for a while longer.
Dr. Hellemans, I know you need.
Yeah, I unfortunately have a thesis defense, the no rest for the wicked here. So I'm just going to say a few words and then I'll leave. But what I would emphasize is be flexible, right? So the greatest, there's a whole bunch of coping styles, a whole bunch of different ways to cope. And what the literature says is that when you're flexible with your coping style, that tends to have the most outcomes. So that's the best thing for resiliency. Learn. So we as a family have been outdoors a whole heck of a lot more than we normally, like we're already an outdoors family, but what we do is we go for walks with my sister and her young baby now that we're back to school. And it's not a good idea for us to be at home inside having dinner together. So we're just being flexible with how we can spend our time with the people that we love. And so I would just encourage and call on everybody to, this is the time to really stretch your imagination. We as humans are huge, we're innovative. That's how we've survived this long. We will innovate our way through this and focus on what you can control. We cannot control when we get a vaccine. We cannot control, our neighbors' willingness to wear a mask, but we can control what we can do. And that is going to make us feel much more psychologically well. So thank you again, everybody. Thank you for joining. And don't hesitate to reach out if you have any further questions. My contact info is all over the net. Thanks, everyone.
Dr. Rood?
Yeah, I was actually dealing with this. I have a lot of hobbies outside of academia, etc. Curling, I'm on a dragon boat team. I do a lot of activities outside in the summer. What we've done is more things like gardening, a lot more gardening than we used to do. So we actually grow all of our vegetables. So I didn't have to worry about lettuce this summer because I was growing. But this winter, you're indoors a little bit more. Curling was very, I curled 4 evenings a week. I'm not going to be doing that this year. But there's alternatives, so I'm going to probably do more cross-country skiing and snowshoeing. I also like to downhill, but I don't want to be in lifts with 4 or 5 people on that lift inside a small box going up Tromloe. So yeah, as Kim said, be flexible in what you're doing, but don't stop doing things. Keep active. Try to be positive as much as possible. I may add, I was at my daughter's wedding, as I said last weekend. Alcohol is not a great thing when you're actually bringing a group of people together necessarily. Sometimes we forget the social distancing aspect of things, and that can result in going within that 2-meter physical distancing aspect of things, and just think about that when you're doing it. And I've heard, I don't know the numbers, but that alcohol consumption has increased with COVID. So you may want to consider that when you're making your decisions on what to do this weekend.
As well as consumption of marijuana, by the way. But Dr. Khan.
Yeah, I think it's a challenging thing, as we enter the winter, so we're still in the fall, it's starting, but as we enter the months, we have more snow and limited options to be outside, I think it's going to become really challenging to be able to, you know, do what we have been doing. So pandemic started in March and kind of entered into the summer, and now comes the time when, as was said, there is this fatigue setting in. It seems to be, and at the same time, we're going to be more indoors. So perhaps you know, keeping in contact with friends and family through Zoom, and there is a lot of sort of physical activities that people would do in a gym. Then, you know, people sort of can make small groups and arrange time to meet and socialize, just to be able to see your friends. I think those are different micro mechanisms that we can think of, but I think it's going to be a very difficult and challenging winter. That's what, at least based on the incoming data and based on the scenario analysis that is coming out of sort of simple models that I work with, it's looking not very optimistic. So I think we really need to ratchet up the coping mechanisms that Kim and others have mentioned to really to dig deep this in the coming months.
Dr. Pychyl?
I'll just end with one thought, and everyone's focused behaviorally. I'll go intrapsychic and say we have to foster an attitude of gratitude. You know, hunt for the good. There are still so many things that are good in our lives, and we will adapt. But on a daily basis, if anything, that positive psychology has taught us that resilience is based on attitude, and one of those foundational attitudes is gratitude. And many of us have much to be grateful for, if not only the fact that we continue to be healthy. So I think we need to focus on that to stay optimistic, even when the winter looks so bad, Dr. Khan.
Yeah, and as a personal note, I think that I'd like to add that even though, you know, we don't all agree on some of the measures, I think that to a certain extent, we're all going through the same thing. So I think a little bit of kindness as well to those, even if they don't agree with their own principles or our own, sometimes, you know, sometimes helps as well. And kindness to ourselves, because one of the things that we, you know, that I have suffered at least is trying to do everything that I was able to do prior to the pandemic, and it's impossible, right? We're living at a time that is truly unprecedented, and as Dr. Hellemans was saying, right, if you need to stay home with your kids because, you know, you can't leave them at home and you have to isolate, then, you know, it's okay not to complete whatever task you had scheduled to do on a particular day. You have to be kind to yourself, because a lot of the times the stressors that we talked about are self-inflicted, right? It's the meeting deadlines that we constantly have, and employers have to be aware of that as well. You know, not all deadlines will be met on time. So I think that if we are aware of that, that would be important as well as a means to dealing with this. So I like at this point, we have some, we have about 20 minutes, 25 minutes. So I'd like to invite people from the audience to ask some questions. There's a question here that reads, the response to stress and stressful situations is fight or flight, or fright, or all of the above, or creativity. What enables the creative response is to have a full use of our mental, emotional, physical, and even spiritual responses. In the last few decades, there has been a rise in suppression of all the above. And individual creative responses will be the key to this. It's a comment, I guess, more than a question. What are your thoughts on this? Is there a belief that there's a suppression of emotional, mental, physical, and even spiritual responses in our society?
Well, maybe it's going to fall on the psychologist to start, but I think it's a big statement. And so it's easy to set it up as a straw man and say, I don't think we can generalize like that, but I do know what the questioner is getting at, that comment. And I think that, you know, sometimes what we call it even more narrowly in our research is amygdala hijack. The limbic system just overwhelms our prefrontal cortex. We're just not able to be planful anymore, organized or dutiful or all those things. And so I think that, you know, as I was listening to you, Alfie, talk about the fact that we have to have some self-compassion, the next step up from that is we have to recognize it's a common humanity. And that brings us full circle even to the notion of mindfulness. And that takes us back to the speaker's comments about if we become more mindful and look at our common humanity, we'll embrace a spirituality that will lead to creativity as opposed to fight or flight, right? We don't have to be falling back on these base responses, but our limbic system will drive us towards that. Make no mistake about it. What we know from research for years and years on stress and coping is that we regress. And the more stressed we get, the more regress we get. And so we can't beat ourselves up for the fact that sometimes we just like to run away or curl up in a ball. But what that writer, that listener reminds us of is that we have so much more capability in us. But to do that, we have to embrace that common humanity and be mindful of the moment. And that's going to help us be creative as a response as opposed to fear.
I have another question from the audience, and this is perhaps Dr. Moloughney or Dr. Root can comment on this, but the question is with regards to vaccines, and the leading vaccine, I guess, is this vaccine by AstraZeneca and Oxford University. I know there's a couple, including one that is being developed by Health Canada as well as a Chinese team. But should there be a vaccine discovered somewhere else, say, you know, the US, how can we ensure that we'll get this vaccine? Or you know, is there a priority for this, or are they going to stockpile it, and are we going to have to wait for that?
Maybe I'll take the question. I know that there have been some agreements put in place already between the Canadian government and some of the big or pharmaceutical sector companies. I saw there was a question on Pfizer, for example, the Pfizer vaccine. Yes, the Canadian government has an agreement in place to get a set amount of vaccine from the Pfizer product. The product from what is it, Oxford as well. I think there may be some negotiations in place. I know there are several vaccines that I think clinical trials are being set up in Canada from a variety of sectors, not only Canadian vaccines, but some international vaccines as well. I'm aware of one. I sort of help people get together between Cambridge University and McMaster University. So yeah, there's a lot of activity going on, and I think, you know, Canada, at least the government of Canada, might have been a little slow in setting up the initial agreements to buy vaccine in spec, basically. A lot of companies, in other countries, the United States, the UK, elsewhere, were buying vaccine on spec. There was no vaccine yet, but they were buying, you know, millions of doses. Canada sort of made some agreements to buy doses as well. Which vaccine is going to be the one that's going to come through the phase 3 clinical trials and going to be scaled up so that we can get billions of doses ultimately is a big question mark at this point. So until that happens, we're all scrambling. We're all doing clinical trials. The number of clinical trials going on right now is amazing. I think there's 280,000 people in the world in clinical trials at the present time. So, you know, we're involved in it. Everyone's getting involved in it. And I think, you know, in the end, we will get access to vaccines. When is another question. Even if we get a vaccine, even if it's scaled up, how long is it going to take between having that vaccine and actually getting it into people's arms or noses or on the skin or whatever approach we're using for vaccination? That may be months to a year.
And in regards to the opening of the economy, one of the questions, I guess, that is in the back of everybody's mind, and again, trying to maintain that balance between economic gain versus keeping our country healthy, is the issue about opening the border with the US. There's a deadline that is looming, I believe. Dr. Khan or Dr. Moloughney, what are your thoughts on that? And do you feel that that's going to be extended? Or do you think that at some point that will have to happen in order to maintain the economy?
Well, I don't really have an answer to that, but clearly, comparing to the pre-pandemic time, the open border is very, very important to the Canadian economy. But at the same time, I guess Dr. Mahoney can comment more on sort of the health aspect of the risk to contagion that would result from an open border.
Right. I mean, in some ways, I mean, there are certain aspects that are open. I mean, certainly, in talking to colleagues in Peel, for example, I mean, they've got lots of trucking that's going across the border. So some trade is occurring, and certainly that's not my area of expertise. But watching what is occurring in the United States from a disease control perspective or a lack thereof is very worrisome. The extent of transmission that has been occurring in a number of states, and it continues to move around, and we're seeing it in some states that it hadn't initially been present, is really worrisome as a source of importation. So I mean, we got ourselves into where we are in Canada at the moment because we had importation of disease into various parts of the country. And we're continuing to live with that. So I think we'd want to be really, really careful about opening up travel to another country that does not have at least the level of control that we have over the disease. And I don't think the United States at the moment would be in that category. Hopefully they will be in that category in the future, but they're not there now.
So, okay, so we have a question that perhaps Dr. Root can answer here. It's a comment again. The AstraZeneca vaccine employs a chimpanzee cold virus as a platform vehicle to deliver the SARS-CoV vaccine. The issue that they are having is that the immune system reacts to the chimpanzee cold virus as a foreign invader. So the result is more immunosuppression. When do we stop? That's the question.
Okay. One of the advantages of using the coronavirus vaccine itself, the chimpanzee adenovirus that AstraZeneca is using with Oxford, is that we haven't seen it. Some of the other vectors that are being used internationally, including the Chinese one, is a human adenovirus vector. So a certain percentage have already come in contact with adenoviruses. So we will respond to the vector, that is the adenovirus, and not to what you're actually trying to vaccinate against. So the whole advantage of using the chimp approach is that we should get a good immune response to what we're trying to get an immune response to, which in this case is the coronavirus spike protein. So that's as far as I'll go. I think the last comment on that question, I'm not going there. Yeah.
So there's another question for Dr. Root. What is the current thinking? So Dr. Root mentioned lettuce. What is the current thinking regarding infection via food, i.e. greens? Also, what is the current thinking of infection via surfaces or ice?
I think Brent could answer these too, but I used to work in the Food Directorate of Health Canada. I just retired from them last year, almost a year ago today. And I would say that the general consensus is that food is not the source of infection. It is not a very good source for infection at all. Surfaces likewise are not the major source of infection. Obviously, doorknobs, if someone's just touched them, they've coughed in their hand and they've touched that surface and you touch it and touch your nose, the chances of infection are a little bit higher. But that's not the major source of infection. The source of infection are very much being in that 2-meter zone, droplet transmission, etc. So I would answer it that way. Food is not likely. remember early on in this, people were disinfecting their food. They were dosing, washing their oranges and everything else. Very quickly, the food microbiology group said, no, that's not the thing to do. And in fact, if you wash your food with detergent, you can actually intoxicate yourself. So no, that is not the source. And everything I've seen so far would say food is not going to be your source of infection.
I would totally agree with everything Dr. Rood said. And certainly when we talk to people, we said, it's people that are the risk, not objects. Because some of even the workplaces that we're dealing with, and they're all so focused on the surfaces and the objects, and said, well, what are you doing about the interactions between your employees at break time, at lunchtime? Those are the sorts of things you need to actually be really worried about, where there's person-to-person interaction, or if you have members of the public coming in, that is your primary focus. The environmental cleaning, yes, you want to do it. You want to clean the doorknobs and the high-touch surfaces, but that is a little bit down the list of worrying about the close interaction between people.
There's a question here also from the audience. Given the comment that
Alfie, can I sort of interrupt? There was a question on my comment on lettuce. Yes, I was making reference more to bacterial contamination in some of the lettuces that we've seen over the last few months. Hence, I don't make Caesar salads right now.
But actually, and this question is again appropriate for Dr. Rood or Dr. Moloughney. There was a comment earlier about the first vaccines that will come out will probably be less effective or less safe. So what would be a suggested principle to follow for seniors, who are some of the people that are most vulnerable? Is it better to wait and see, or take the first vaccine available? Thank you for the session is the last comment.
I'll add to that. It's Erling again. There's a couple of issues here with the seniors. They obviously, if they do get infected, the prognosis is the worst of all the age groups, in the sense that they do have a higher incidence of dying of infection. However, once you get to 40 years old, I'd hate to tell everyone here, but once you get to 40, your immune system starts to slowly shut down. So the responsiveness of the elderly, that's the over 65s, to vaccines in general is not very good. They just don't respond very well. So we were aware of that. Flu, it was very well known. In fact, my first project in 1978 was to try to understand why the elderly don't respond to flu vaccines. We're still asking that question. But basically, it's the immune system doesn't function as well. You seem to have a different type of immune response which predominates in the elderly. One of them being an inflammatory response, which is the worst response you'd want to have to coronavirus infection, because it would worsen the prognosis. So there's multiple issues there. I would say a vaccine that's partially effective in the elderly is better than no vaccine.
Dr. Moloughney, anything you'd like to add?
Yeah, I mean, just that, whichever the first ones that are out, Canada may not actually purchase those. They'll be looking at the effectiveness, and they'll be trying to decide where do we get the biggest bang for the buck. And so there'll need to be some strategic decisions as to which one or two vaccines is Canada going to go after. And I would agree that a little bit of protection is better than no protection. And especially because this is going to be more than just individuals. This is going to be collective in terms of the people around us also being eventually immunized, and so that we end up protecting each other, in addition to the non-pharmaceutical interventions such as masking and distancing. So there'll be some interesting decisions that will have to be made on a national and provincial basis for purchasing decisions. And I think the initial decisions will be there versus what an individual senior, for example, needs to decide.
I'm going to add as well, I used to work with the Public Health Agency of Canada, and we were supporting the National Advisory Committee on Immunization. And one of the strongest messages that were coming in from the province was that when we make recommendations, we didn't have a health economic recommendation to be put forward in regards to vaccines that were being promoted for the provinces to buy annually. So the response was the National Advisory Committee was supported by health economists to provide that lens to help their decision. So I'm assuming the same type of approach is going to be happening now at the Public Health Agency. However, I haven't worked there since 2016, so I'm not privy to the internal workings of FAC anymore.
I have a question here for Dr. Khan, and it reads, from an economical perspective, is it a bad time to set up a new business, say e-commerce, during a global pandemic? If yes, how many businesses, how may new businesses plan a good mitigation as well as set up an optimal business plan to get this into place? And there's a thank you.
Yeah, no, I have to admit that I won't have any kind of specific business setting up advice, but it is the service industry that has taken a huge hit in this pandemic. And there is a lot of innovation that is going on in service industry. So just take some examples, sort of the delivery service, so there is many variants of this delivery service that are coming up. So there seems to be a lot of room for innovation there. And my sense is that it will all depend on sort of the innovative idea and what need does it fulfill, so that would be sort of the key in doing initiating a new sort of business idea in a pandemic.
Okay, so there is a thank you note here from one of the members of the audience to Dr. Ruud, thanking him for highlighting the distinction between the human and chimpanzee adenoviruses, RE immune responses. At this point, we have one more question. And after this question, we will end the panel. The question reads, the pandemic seems to have had a magnifying effect on economic disruption, health and mental well-being, and societal impact. In hindsight, could the magnitude of these impacts have been predicted? Was it simply a matter of a perfect storm? What lessons can we take moving forward to ensure that we're better prepared and that we have a higher degree of resilience in these areas? Perhaps Tim can start with this.
Well, thanks a lot. Throw me in the deep end. That's a huge and difficult question.
Yeah, I think everybody can contribute to it. So.
Oh, I'm not muted still. I know, good. So, hindsight is 2020. And as I read that question, I think, is it a perfect storm? No, it just seems like one horrible hurricane, right? It seems to be one effect that's just disrupting things like our ability to work being first and foremost, and then the existential threat to ourselves. Could we do anything better? Well, I think we can always create stronger social ties, whether that be through government or through community. And that's where we're seeing things amplified, as we heard in some of the first comments that Brent made, and the differences in social groups that Dr. Khan made, that we are seeing it magnifies existing problems. So if we want to be more resilient in the future, we'll take this to heart and we'll fix those existing problems before the next pandemic, or as people will say is on the horizon, the coming effects of climate change, as an example. It's no different than other things we've seen, whether that be a flood, right? Well, then we have to look at repairing some of the infrastructure that we neglected because they're only every 100 years we see this kind of water level. So I think the answer lies in strengthening community.
Just to comment, I completely agree with what Tim mentioned. So as we are talking about there's a lot of discussion of sort of tracking and tracing and developing tests that can be done at home, or sort of reducing the cost of doing these tests and processing them, and so that we can expand this testing. This is more of an infrastructural investment. You can view it that way. And so in the lesson that we can draw from this is that we can never predict what kind of pandemic we might end up in 5 years or 10 years from now. But we will have the capacity to say test very quickly, maybe adapt the tests and scale up quickly. So these are the kind of things that we'll be better prepared from that perspective. So of course, no one could have predicted the scale of this global pandemic, but I think if there is a future pandemic, or when there is a future pandemic, we may be better prepared to use some of the infrastructure that we're building. That is sort of a more optimistic perspective, I think.
This is Erling. I'm going to sort of give maybe a little less optimistic. I went through the AIDS situation, went through SARS, H1N1. We deal with pandemics somewhat in a hindsight view. It's very difficult to get support for infrastructure to maintain our systems at elevated levels. Once a situation has passed, a couple of years later, the funding starts to dwindle. It's very difficult to maintain it. We know there's a project I've been following for the last 5 years or so called I think it's the Human Virome Project, that is looking at the potential zoonotic agents, so viruses that could come in from different animal sources. And right now, I think the project has documented over 850,000 different viruses that could be coming at us, of which I believe about 30,000 would be coronavirus-like elements. We've seen 4 of them. So it's not when, it's not if, it's very much when. And with globalization and you know our traffic of people all over the place through vacations, globalization of our businesses, etc. It's a perfect storm without a doubt. It is allowing these viruses to get around very quickly. Projects like the Human Virome Project are allowing us to identify fairly quickly. In fact, this virus is very similar to a virus that was identified through the Human Virome Project. It was a bat virus from the Yunnan province. Not identical, but extremely close. So that helped out a lot, identify the initial virus back in January.
Dr. Moloughney, any?
Yeah, so wow, so huge question. So echoing Dr. Rudd's comments, I mean, having watched the responsiveness of provinces, territories, and the federal government after SARS, where we built a lot of public health infrastructure. That was the birth of the Public Health Agency of Canada nationally. It was the birthplace of Public Health Ontario as the provincial agency here in Ontario. And so there was a lot of work, and actually as a consultant, I did a lot of work across the country dealing with public health system infrastructure for a number of years. What I saw maybe about 5 or so years ago, the appetite decreased. I remember I would start giving examples from SARS, and people would look at me and go, "We don't want to hear about SARS anymore. We're tired of hearing it. That's old news. The SARS message is old news. We're ready to move on to other things." And so we do have a tendency to forget. I mean, there were, you know, fairly major cuts announced for local public health in Ontario just a couple of years ago. Fortunately, those were not implemented. Otherwise, we would have a lot less capacity on the ground than we do. So there's that piece where it's been, you know, emergency after emergency, decade after decade, where we go through these pendulum swinging sorts of policy experiences. My final comment, though, is hopefulness, I guess, in terms of maybe we take the lessons learned around social determinants. Like, this virus has really exposed what has occurred over a period of many years with respect to housing policy, with respect to marginalized populations, with respect to the infrastructure for long-term care. So hopefully the lessons learned, hopefully we don't have to wait till at the end of this, we can work on it earlier, is to address those areas because, you know, boy, this virus has really exposed those vulnerabilities. And hopefully we can make improvements and have stronger communities, because if anything, this virus has showed how interconnected we all are. Hopefully we take that lesson from a positive perspective and we strengthen the infrastructure and resiliency of our communities.
So with those comments, I want to thank all the members of our panel, Dr. Moloughney, Dr. Hellemans, Dr. Rood, Dr. Pychyl, and Dr. Khan, for this very insightful panel. We received some very, very fantastic questions, and I think that we're all leaving with a little bit of extra knowledge home, and I hope all the members of our audience feel the same way. With this, I declare this panel finished. Have a wonderful day, everybody.
Thank you. Thank you very much.
Thanks very much. Bye now.